My name is Mahsheed, Khajavi. I just came here a few months ago from Atlanta, and today is actually National Advanced Directive Healthcare Planning Day, so it kind of fits with this. This is actually a subject that's kind of close to my heart. We, as physicians, do a lot of medical care, and as an inpatient physician, 100% of what I do is in hospital. So we have a tremendous number of patients who end up on our intensive care unit on ventilators and intubated and unable to make decisions for themselves. Family members come along. Often there's a lot of friction and tension as to what some of the family members want, what other of the family members want. And I'm always kind of surprised that people just don't address this when they're healthy, when we're okay and in a healthy state of mind, so that it will come to what to do for a person when that person can't make a decision about his or her own health care. So this talk is about planning for end of life. Okay, so essentially it's pretty easy. There are two basic choices. What is it that we want, and what is it that we don't want? Outcome studies have shown us it's based upon essentially four things. Belief systems, meaning religious affiliations, spiritual belief systems, a person's personal values, what is it that each of us hold valuable about living, character traits, who can coping mechanisms, and what we can tolerate personally in terms of pain, suffering, family. And basically it comes down to how do I want to live, and what is meaningful in my life, and what is worth going through to prolong my life. And more importantly in this scenario, how do I want to die, and when does the line come between prolonging life and just prolonging death? So why is planning important in this discussion? What do we need to consider? How do we plan for our end of care decisions? And who do we need to include in these discussions, and how do we go about doing it? That's kind of the four things I wanted to go through. It's interesting to me that when I was going through the literature, 88% of Americans are perfectly comfortable talking to people about issues related to dying and death, but only about 1 in 5 of us have a living will or a durable power of attorney. And what I found even more interesting is in healthy states, only 12 to 20% of providers ever talk about this with their patients. So the result in this country is that an excessive number of patients receive aggressive care at the end of their life. And depending on the studies, 1 out of 5 patients receive what's called futile care. Futile care is care that is deemed by 2 or more physicians to be absolutely, unequivocally irrelevant, and regardless of the intervention, the patient is going to die. That is futile care. And I will just tell you, last week we had a patient who was diabetic and had hypertension for years, and just didn't take his blood pressure medicine, and came in with a blood pressure of 360 over 150, which is very high, had a bleed in his brain, and after came in and had no cerebral function. He was deemed what we call kind of colloquially brain dead. He had what we call anoxic brain injury, and he had no function at all. Gets put on a ventilator. He was 62 years old, gets upstairs. Now this man is on a mechanical ventilator, breathing for him. We have IV fluids. We have medication to keep his blood pressure up. And the family wanted to have everything done because they didn't know what his wishes would be. And so he slowly and horribly died over the next week. Well, we knew as healthcare personnel that this is of no benefit. This is absolutely unequivocally of no benefit. But we didn't have any guidance from him as to what he would want, what this would happen. So what's an advance directive? An advance directive, it's a written statement of one's wishes and decisions regarding end-of-life healthcare decision. It's a tool. It helps you think through what it is you want and don't want when the time comes to make a decision when you can't make it yourself. And it's a roadmap for your future health care. And it should always be made when you're healthy and well in discussion with your primary care provider. And who should, and I'll tell you what a healthcare proxy is, but who should have a copy of the advance direction? Absolutely the physician, family members with whom one is close, a husband, a wife, children, your attorney, and your healthcare proxy. So written instructions about future medical care in your advance directive are only used with a serious illness and when you can't tell people what you want anymore. And the two kind of main components of that are a living will and a medical or healthcare power of attorney. So what's a living will? A living will is a legal document. It says what your personal wishes are regarding medical treatment. Whether in certain circumstances you want to allow natural death, or also known as do not resuscitate, when you would want to be on a ventilator, on a breathing machine, when you would want to be shocked, have your heart shocked, when you would want feeding tubes. It's designed by you when you're healthy. And it's very specific. You can make it very specific. I have a living will. I'm 50, but I have put in my living will, if I have a pneumonia and I know I'm going to get through this pneumonia and I'm going to be on a ventilator for 3 days, put me on a ventilator. If I am brain dead from a car accident, don't you dare touch me. And it's 4 pages and it's very clear. So you can make it as specific as you want, and the more specific, the better. It's a legal form, and that's your living will. So what is a medical power of attorney? So the medical power of attorney is the form which says who is going to make decisions for you when you can't speak for yourself. Sometimes we run into a problem where someone does have a living will. We don't have a copy of it. The physician doesn't have one. It's not, the nursing home doesn't have one. But if you have a medical power of attorney, it's also called durable power of attorney, healthcare surrogate, there are a bunch of people. That person has been instructed and delegated in writing to make medical decisions on your behalf. So for me, it's my brother. I have spoken to him at length as to what I want. He has spoken to me at length as to what I want. So if I have a car accident and my living will is not in my bag, he'll come to the hospital and say, here, I am her medical power of attorney. I know what she wants. I'm going to make her health care decisions and take it from there. So that's our person. So here's this scenario. A 62-year-old male with hypertension. He comes in with severe headache and vomiting. He stops breathing. He gets intubated. We do a CT scan of him, and he has a huge bleed in his head. And 24 hours later, we do the functioning to see if someone is legally brain dead, and this man is legally brain dead. He has no living will. He has no power of attorney. At this point, what does the family do? Do you continue breathing for him? Do you start him on a feeding tube? Do you start him on IV nutrition? Do you pull the tube? Do you call hospice? If he had some power of attorney or living will, we would have known. But as the care providers, we are obligated to do whatever it takes until a decision is made. And I will tell you, it was really a struggle. His wife wanted to let him go, and his children didn't, and it was very ugly. And it kind of split this family because of this decision. So here are some problems and worries that people have. If I have a living will, no one's going to try and save me. It turns out, medical studies show, people actually have the same length of survival and have more intimate care when they are placed on hospice or when they have a living will. Because family members know what they want, medical personnel know what they want. So if someone comes in and has a living will, it actually turns out that everything will be done short of what you don't want. Does stopping treatment mean stopping care? No, it doesn't at all. if you have, we had a few weeks ago, an unfortunate lady who had metastatic breast cancer to her brain and her liver and her lungs and her bones, and she had a living will. And she said, I don't want to be put on a breathing machine, but I do want to be comfortable. So we got her into hospice, and she had a nurse, and there were 3 nurses when she died, and she had good pain medication, and the chaplain was there, and she crossed over very comfortably. So it's not stopping care, it's just a different kind of care. Can I die from lack of food or fluids, and is this painful? Well, I personally couldn't die for lack of food for a very long time. You know, you can live off your body fat for a while, but fluids after 4 to 5 days, yes. Is it painful? No. If you are no longer able to make decisions for yourself, and a decision is made to make you comfortable, the medical community is very aware of what that means. We have a very interested palliative care nurse and palliative care team, physicians who hone in on making you comfortable even if you're not getting food or fluids. This is the big one for us. So what are people going to think if I'm the medical power of attorney and I say, you need to stop treatment? Well, the fact is, I always tell my folks, you have to make the decision based on what he or she told you, out of respect to him or her. You are not, you know, it doesn't matter what other people, this person trusted you enough to trust his decision-making or her decision-making to you. And what this person wants is what you have to do. You have to honor that. And most people who are close enough to someone to make them a medical power of attorney are good with that. The problem arises when family members like this person who had the bleed say, well, God, if I take this tube out of him, people will think I killed him. No, you didn't kill him. He's already brain dead. It puts a burden on people that shouldn't be there, because we're artificially keeping somebody alive because there's a heartbeat, but is that really alive? And will I be giving up on the patient if I decide to take him or her off mechanical ventilation? Well, I've always told my patients, if I go to somebody, for instance, and forgive the analogy, but if I go to my mechanic and my mechanic says, your transmission's not working, your engine's broken in half, you don't have brakes, and your car won't turn on, and there's no battery. I think we need to just let this stop, and you need to think about some other options. Well, I get that. Family members are forced to make decisions based on knowledge they don't necessarily have. I mean, as a physician, I can say this person has no higher brain function. This person has a heart that's pumping 5%. It is not going to suddenly pump 70%. This person has end-stage lung disease and is never going to get his lungs back, and this is futile treatment. Well, family members still have an emotional attachment because they think, well, what if? What if it's the 1 in 20,000, you know? So, but the truth is, it puts a burden on the family to make medical decisions based on not having the medical know-how. It's, so no, if you decide to take a patient off mechanical ventilation, that would be either 1, by his choice or her choice having told you before the situation, or 2, because the physician has sat down and said, this is where we are, this is how far we've come, this is futile care, and taking someone off mechanical ventilation is not causing their death, it's allowing a natural process to occur that is going to occur anyway. So, some things to think about. A living will is your expression of how you want to define your life and your death. It's a will that lets your family, your physician, your power of attorney know when you will agree to tubes, machines, resuscitation, when you will be on a ventilator, when you don't want to be on a ventilator, at what point you can designate, I'm willing to be on a ventilator for a week. If the physicians think this is no longer, you know, an option that I'm going to survive, I want this ventilator off. It's your decision before someone else makes that for you. And it provides guidance to family, to healthcare personnel, and to your proxy, what is to be done for you when you can no longer make that decision. And the most important thing, which we in the ICU see a lot, it alleviates tension and lifelong guilt among family members. So the bottom line is we are in charge of our own life and our own decision making. And I always find it kind of interesting that we're so keen on being in charge of our home and our job and our other decisions, but something so absolutely important and profoundly important we just kind of avoid, including physicians. I mean, if only 1 out of 5 physicians asks a patient, what is it that you want at the end of your life or with a terminal illness, we are just as responsible. Document what it is you want and what it is you don't want. That's the living will. Designate a medical power of attorney, and that is the person who'll know what your expressed desires are and do it in writing. Make certain to discuss with your physician and keep a copy available. Review your medical decisions with your physician and get information needed to make the decisions. And just as an aside, you don't need an attorney in most states. In Georgia, you don't. 2 signatures and a notary covers it. This is a very good resource, caringinfo.org. It gives you all the state-specific guidelines. It goes specific through what a living will is. You can even print one out. It goes through in what conditions you want and don't want things to be done, and how to designate a power of attorney. Pretty much anything you could want, it tells you. And I think that's it. Questions? Yes, ma'am.
Could you define what they mean when they say medically induced coma, and who are the patients that you do put for medically induced coma?
So some patients are on a ventilator, and we think that this is a disease that can be reversed, like a horrific pneumonia. But they are so agitated despite our medications that it's causing more harm. So we give them medication to just completely, essentially paralyze them so that we can get through that period and then get them out of it. That's a medically induced coma. And we don't do it very often. I may do it 5 times a year. So, do you have someone in a medically induced coma? Did you know somebody who was in a medically induced?
It's in the news all the time. Like Joe Rivers was put on a medically induced coma, and then there's this daughter of Houston Whitney who was put on medically induced coma. I don't know what the prognosis is.
That's really a medical intervention that helps get them through, if they're going to, that ventilation period. It just allows them to be completely relaxed, and so that the ventilator can breathe for them.
So it doesn't always mean that there's no hope?
Oh, no. No, not at all. Not at all.
Thank you.
Any other questions? Yes, sir.
How often should you update this living will and power of attorney? I'm thinking in terms of medical advances, because they seem to be, developing new procedures, new drugs, etc., rather frequently.
I think that that's a great question. I wrote mine about, let's see, I'm 51, 7, 8 years ago, and I never have updated it. And the reason is because your living will is what happens if you are at the end of your kind of life. So all of those interventions would occur prior to being at the end of your life, meaning with our new chemotherapies, with our new immunoglobulin therapies, you would get those. So, I think the recommendation is every 5 years to update it with your primary care physician. 5 to 7 years is the recommendation. Any other questions? Yes, ma'am.
To piggyback off what this question was, with the living will being updated, for instance, you say it's your brother for you. Say, for instance, it's my brother. and I get married a couple of years later, and I discussed it with my brother, but now I have a spouse. Because I mean, I've seen in the past where things get a little sticky with family members. And you know, people who didn't have a spouse beforehand, or people who have spouses that are estranged, and they come out of the woodworks when the patient is on their deathbed. So could you speak a little to ethics and who that usually entails, like in this hospital, and at what point would they step in to diffuse a situation like that?
So that is a great question, because we have had that issue many times. But if you designate a medical power of attorney, no matter what anyone else has to say, that person makes your decisions. So if you get married and decide that your husband's going to be the person, then you would change it. If you are estranged and you decide your brother's going to be the person, then you would change it again. So whoever has that power of attorney, medical power of attorney, doesn't matter, it trumps everything. The problem comes when, and gosh, we have seen this so many times, you have a 70-year-old who's been separated from her husband for 10 years, right? And she has 2 children, and she's very close with them. And something kind of, she has what we call a cardiomyopathy. She has a heart that pretty much has stopped functioning. And she is on a ventilator, and she has told them, but not written. You know I've been like this for the last 8 or 9 years. I've lived 5 years longer than I should. You know, when I have my cardiac arrest, I don't want anything done. So she has told them that. But then she never wrote it. She didn't give him a medical power of attorney. Husband, who's still legally married in the state of Georgia, has first dibs. So if you are married, even if you are separated, and you don't have a living will, he's the person who can say, do it or not do it. We had a very interesting case several years ago, which was extremely distressing to me, with a lady who I actually thought would pull through. She had what's called MRSA pneumonia. It was going to be a rocky course, but I really had a lot of faith that things were going to get better. But I knew she was going to be on the ventilator, and we knew she was going to be tubed, and we knew she was going to need artificial nutrition for a period of 6 to 8 days. And her children, 2 sons, she had twins, were close with her. And so I explained all that to her. She also had $1 million life insurance policy. And her husband, who had been with another woman for the last 5 years, came in and said, turn everything off, let her die. I went to the ethics committee and said, I can't do this. And the attorney said, he has the medical power of attorney. And I said, I don't care if he does or he doesn't. I can't do this. Legally, I was totally in the wrong. Luckily, we drug it out enough for several days that she got better and we got her off the ventilator. But I was not legally in the right. I have to do what's moral and what's ethical and what I think is between me and my God. So at the end of the day, it doesn't matter to me. But it was a very bad situation. Those were his children too, and they hadn't spoken to him since he went off with that other lady. And but if you don't designate someone in the state of Georgia, the first person is your spouse, followed by your children. And then it goes to the next degree relative, next degree relative. They do. Yes, ma'am.
Next living relative to child, or could it be a sibling?
In Georgia, it's spouse, children of legal age, siblings. Any other questions?
You may address, is there a provision for if you think a treatment might work?
Mm-hmm.
I think there's a lot of confusion about fees and things like that. Can you have a feeding tube for a little while, and then when things don't get better, you can still, you can opt to take it out, or is it just, it's like a myth that once you put a feeding tube in, no one can ever take it out?
Oh, no, that's the wonderfulness about this. My own living will is pretty specific, and I will tell you, I was engaged to somebody before I married my present husband, and he had a very bizarre accident at the ocean, and he got caught by the undertow, and fell on his neck and ended up with a cervical spine fracture. And we got to the hospital, and I knew this man very well, and he was a flight nurse, and I knew there wasn't a chance on God's good earth that he would want to live as a quadriplegic. I knew. And his son, who was 18 and very attached to him, was insistent that they keep him on the ventilator, and he ended up in the hospital in kind of a horrific way with bed sores and feeding tubes, and died after 2 weeks. But had he had a living will or a power of attorney, which we never even thought about because we were 29 years old, and who thinks about things like that, he would not have had to suffer that misery. In my living will, I say, if I have this, and if the physician thinks that this is reversible, that this is something reversible, if I have a bad infectious disease, H1N1, Ebola, whatever, do everything you can to the point where you feel that everything has been done, this is not reversible, then turn the vent off, take me off my tubes, and send me home with my family. So you can be, that's the beauty of it.
Hoping to get better.
Absolutely, that's the beauty of it. Yeah, and that's why people say, well, they won't intubate me if I have a living will. That's not true. As long as you say what you want, that gets followed. It's just instructions for when you can't tell people what it is you want, Any other questions? All right. Yes, sir.
I know that you said that you don't have to have an attorney, but your power of attorney and your living will, I guess more specifically, sounds like it's very specific. Did you go to a website or a particular organization to format your living will?
So I kind of am lucky because I'm a doctor, so I know this stuff. But that last slide that I showed you, caringinfo.org, that you can actually download everything you need, different templates. It actually takes you step by step through, what is it that you want? In this circumstance, what is it? And then you can just print it out. But most of the time I tell my patients, talk with your doctor, talk with your primary doctor, have an hour-long conversation as to what it is you want and don't want, and so that people know, Yes, sir.
Everything you've talked about is up until the point of death. But there are decisions that need to be made after someone passes away. Is that part of the living will, or is that I'm not sure that's part of the will. Let me give you a specific example because it happened to me. My father passed away, and we were trying to figure out what to do because everything was very stressful at that particular point. And what we found out was there was an organization in Florida that had to make a decision regarding, this sounds clinical, but disposition of the body. In other words, are you donating your organs? And we could not make arrangements for the funeral home because this organization had to be contacted and they had to have some kind of a release.
I have never heard of such a thing.
Well, the state of Florida, it was required.
It was required, and this happened on Friday night, and they weren't going to be able to do anything for the entire weekend, and the whole thing was.
No, there is kind of a law that if you come to a hospital and die within the first 24 hours, or if it's an unexpected death, that it becomes a coroner's case. And the coroner has to make sure that it was a legitimate death. How ridiculous is that? And then the body can be released. But that's the only circumstance I know federally that's the case.
Well, that's not what happened, and it was not that kind of a case at all.
I honestly have never heard of it. Have you?
We were shocked
shock.
Yes.
And they held his body at the hospital. And of course, my mother-in-law was very sad. But basically, she had to get involved in this before they would release his body to the funeral home. Didn't have anything to do with an autopsy. He'd been in the hospital for 2 weeks.
I would love the information, and I will get back to you because I have never heard of such a thing.
It was horrendous for a family to have to go through.
But it's some kind of a law in Florida, because they said it was a law. The hospital could not release my dad's body until this organization, and they were in Gainesville, Florida, and it was a very disagreeable experience.
Oh, I'm sure.
It was a donor organization for tissue.
It's probably Lifelink.
No, Lifelink is George's name.
Oh, that's George's.
Yeah, that's
Now, did he have on his driver's license that he was an organ donor?
No.
But I've never heard of an organ procurement agency saying that.
Right, I've never known even Lifelink to hold anybody.
They don't. I mean, the faster they can get organs, the
Now, I do
better.
know Florida has a law that if you are moving a body across state lines, Florida does have a law that you have to be embalmed. But
Honestly, I'd love the information, and I will look into it and get back to you. But in answer to that question, I think it's the thing you put in your will. That, right, when after my death, I want to be, buried, donated, cremated. I think that goes in your will.
Now, my advance directive that I have on file here, it states that I want my organs to be donated. So in the event that I can't speak or anything, if there is anything that is viable, the hospital would know to do what needed to keep my body viable until those organs can be removed.
Mine does too.
Right, and whenever you have the advance directive and you give it to your family, you give it to your attorney, you also need to give it, especially if you live like I have all my life in Thomasville, I have a copy of it here at the hospital. And so it's always a part of my chart, regardless whenever I come in, I have my advance directive and it's available to whichever doctor I'll have.
I actually took a picture on my smartphone, and I have it in my Gmail file. Because you never know. We walk around with our phones all the time.
And whenever, if you are admitted to the hospital for anything, the advance directive can always be printed out. You can initial it, change it, like if there's some change in phone numbers or anything like that, and then it would go back through medical records to be rescanned as the current updated advance directive.
Any other questions? Well, thank you, everybody. Get out of here. Thank you.
good evening. My name is Anna Brinson. I'm a patient representative here at Archibald Medical Center, and I've been with Archibald now for 13 years. I did spend 5 years with hospice, working as a bereavement coordinator and therapist over there. But I've always enjoyed being a patient rep. I started out my career at Archibald, and so I came back several years ago to return to this position. And one of the things that I do with patients and families is we are a Medicare and a Medicaid funded facility. So therefore, we are required by law to offer patients advance directive information and information on how they can actually complete an advance directive. So we are very blessed by the Archibald Foundation, but we are very blessed by the Archibald Foundation that we are able to give out to our patients the Critical Conditions Planning Guide. And I'm very passionate about this booklet, and as I talk about it, you'll see why. But I want this to be very interactive. I want you to feel like you can ask me questions or stop me, because I'm actually going to try to briefly go through the book. And so just ask me questions as we go through the booklet. But I'm going to ask you all a question first. How many people in here already have an advance directive? Okay. How long has it been since you reviewed your advance directive? 2 years. 10 years. Okay. Is your advance directive older than 10 years? Back in 2009, Georgia changed their format a little bit. Used to, back in the late 90s and 80s, when you went to a lawyer or went to a hospital and had an advance directive, they would usually give you just a 1 to 2 page form that was a living will. And Georgia in 2009 changed that a little bit and went to the Georgia Advance Directive for Healthcare. And what I like about the Georgia Advance Directive for Healthcare is it's a 2-part document. The first part of the document allows you to declare a healthcare agent. And I'm on page 15 if you want to turn with me, 31 in your booklet. I'm sorry. I'm on page 31. It allows you to declare a healthcare agent. A healthcare agent is the same thing in the state of Georgia as a durable power of attorney. Now, if you have a power of attorney drawn up in the state of Georgia, 9 times out of 10, your lawyer has included a durable clause in there that allows your power of attorney to make healthcare decisions for you. But you must read it, because sometimes it is strictly financial. But most of the time in Georgia, they include that clause. However, it's only about this big. Whereas if you go and fill out a Georgia Advance Directive for Healthcare, you're going to give that power of attorney, or that healthcare agent, if you will, information about what your end-of-life choices would be in much more detail, so that they have a little bit better understanding of what is important to you and what your wishes would be. Now on page 31, you'll see the first one is your primary healthcare agent or healthcare agent. And that can be anyone that you want it to be. It can be your spouse. It can be your children if they're over the age of 18. It can be a sister or brother. It can be a good friend. And just like the young lady over here that asked a question earlier about advance directives and how that order goes, legally in the state of Georgia, if you do not have an advance directive, if you are legally married, your spouse has the ability to make healthcare decisions for you. And like Dr. Khajavi said, we've seen it many times. I've been on that side of the bed in the hospital where you have a spouse that has been estranged for many years. Do you really want that person making healthcare decisions for you? Sometimes you need to think about lots of different scenarios. And I try to tell people, whoever you designate as your primary healthcare decision maker needs to be someone that knows your wishes and that you know would follow through with those wishes. But it can be anyone you want. But by Georgia law, if you do not have that, it will be your spouse. If you have children over the age of 18 or older, it would automatically revert to them if you're not married. And then if your children are under the age of 18, it would be a sibling. But if your children are over the age of 18, then they can make those decisions for you. But I tell people when I'm working with families and going over these booklets with them, I tell them your healthcare agent needs the person that can get to you the quickest and follow your wishes. And so that's your primary. But on this document, you have the ability to name up to 2 more people. So it could be like on my advance directive, I'll use myself as an example. My sister is my healthcare advance directive. I'm married and I have a husband and I have him listed second. However, my husband does not do well with health stuff. He does not. His advance directive, he wants everything done to keep him alive, and he tells me that every day. He knows I work here, and I think he thinks I'm going to pull the plug, but I'm not. But he doesn't fail to tell me that every day, not literally, but but I know my sister would carry out my wishes, but I still want her to include him. So I do have him listed. So, but I know my sister would really guide him a little more and kind of say, you know, this is really what Anna would want, and I think we need to consider this. And she would kind of guide him a little bit. But it really can be just whomever you want it to be. Also, one thing that I like about this is you all know that every time you go to the doctor nowadays or you come to the hospital, what is the first piece of paper they ask you to sign? It's a HIPAA release. Healthcare Information Portability and Accountability Act. That's one of the first papers they ask you to sign. This also lets us know as a hospital who we're allowed to discuss your health care with. Not just anybody can walk in and say, I want to know about Miss Jones. We need to know that we're allowed to talk to that person about Miss Jones. But do know that this is just giving them information. This does not, your healthcare agent is not making decisions for you until you're considered incompetent. And that can be permanent or temporary. But we can still give them information about you. That's about the healthcare agent. Basically, the healthcare agent can do anything you would do for yourself, except they cannot commit you to a psychiatric hospital and they cannot have you sterilized. Those are the only two things they cannot do. And it's in the booklet. So, on the second page, you give your, which we're going to page 32 now, you actually give your healthcare agent powers. And like a power of attorney, a healthcare power of attorney ceases at death. So, kind of like some of the questions you were mentioning earlier, you're going to give that person instructions as to what you want done after you are deceased. Now, you have the choice of autopsy, organ donation, and the disposition of your body to a medical study program. If you come into the hospital and you die within 24 hours, you're automatically going to become a coroner's case. That doesn't mean that there's foul play involved. It's just a matter of formality. Now, that doesn't mean we're going to keep you 24 hours. We just have to notify, the coroner that you're deceased. But there are certain religions and personal views about autopsies that some people choose. They do not want any kind of anything done to the body after death, and that's certainly their wishes. So they might want to say, well, I don't want my agent to have the power to authorize that. The only thing I can tell you is that if there is foul play involved or you're a coroner's case, we have no control over an autopsy by the law. But if you have personal choices about that, you can decide how you want to give them powers. The same for organ donation and the disposition of your body. I did not know till I came to work here that if you want to donate your body to a medical study program, there's quite a lengthy process to that. It's not just something you can call up or have the hospital call up and say, well, Miss Jones passed away and she wants to donate her body to the Medical College of Georgia. It's not that easy. If you're interested in that, if you will see me afterwards or contact me later on, I'll give you my contact information. I can give you information about that. As we go on to the next question, which is C on page 33, it's about the final disposition of the body. You can appoint the person that's your healthcare agent to make those decisions for you, or you can designate someone else in your family. It's really your choice, and it does give you the option to be buried or cremated there. But you're just giving them a little bit more information about what your wishes are. Part 2, which is also on page 33, is your treatment preferences. And this is actually going into a living will questions. And I like to tell people when I'm working with them, there's no right or wrong answer on your living will. It is truly a personal choice based on your value system, based on your belief system. So remember, I may put my things one way, you may put yours another, but there's no right or wrong answer. It's truly a personal choice. And you're going to choose the conditions. And kind of like Dr. Khajavi was speaking about fetal care, most of the time in order for a living will to be activated, 2 doctors are going to be in the hospital working with you and your family, and they're going to come to you and say, we are at a point in Mr. or Mrs. Jones' care in which we need to think about what their end-of-life choices are going to be, or have they made those decisions in advance. And sort of usually they're going to begin to prompt you, because a lot of people, like Dr. Khajavi said, they think if I fill this out and then I come to the hospital, that means nothing else is going to be done, and that's not true. It's basically when 2 doctors have decided that there's nothing else medically they can do, that in a reasonable amount of time you're going to pass away. So, but it does talk about a terminal condition, which is incurable or irreversible, which would be like cancer, and we're talking end stages of cancer. You can get a cancer diagnosis and go through treatment, and it's still not time for your living will. This is when they have gotten to a point where there's nothing else medically they can do. And the other is a permanent state of unconsciousness, which is an irreversible type coma or brain death that they talk about in the conditions. And you can choose those as well. You can choose both of them or you can choose just one, but it's your choice. And then you go over to treatment preferences. And I just kind of preface this a little bit for you on page 34. And if I'm going too fast, stop me because I do have a habit of talking fast. So, but you have actually 3 choices. The first choice, which is A, which is try to extend my life for as long as possible using all medications, machines, and other medical procedures that in a reasonable medical judgment could keep me alive. If I'm unable to take nutrition or fluids by mouth, then I want to receive nutrition or fluids by tube or other medical means. This is aggressive treatment. This means that if you want everything done medically to try to sustain your life for as long as possible. That's a choice. Your second choice is to allow your natural death to occur, which is basically to remove all machines and remove aggressive treatments at that point. That does not mean that you still won't get pain medicine or that you won't get some type of comfort measures to help you with the symptoms that you would be going through. They're still going to give you comfort care. We're really blessed. Jayne Murray's here tonight. We have a new palliative care team that is looking into helping families as well as hospice make those decisions and talk to you about those things. And that's fairly new to us, but we're really happy that we're able to start that service. C is a little more aggressive than B, but it allows you to kind of choose what you may or may not want when it comes to life support. Some people have definite feelings about food and nutrition. Or maybe your religious belief is you do or do not want any type of blood products or things like that. You have that option to pick those things and put that down. And there is a section under 8 there at the bottom on page 34 where you can be a little more specific if you'd like and put those, anything that isn't listed, you can put it down there. But C means that you basically want to try something. I think someone maybe had a question about that, about if you begin something and you see that it's not working or that it's not benefiting the patient as much as they thought it would, can it be removed? And that is a possibility. You can have that done. That is an option. Number 9 is for women. In case of pregnancy, of course, a living will is not activated at that time. You all might remember recently, well, it's probably been about a year ago, there was a lady in Texas that was pregnant and she was on life support, and there was her husband wanted to terminate life support because he knew that she would not want that, but there was some question of the viability of the fetus, so therefore in Texas they kept her on life support. And so that's going to happen in most states. Part 3 is guardianship. Guardianship is appointed by the courts, but this gives you an opportunity to select someone or recommend, basically, if it went to a court judge, who you would like your guardian to be. That's very rare. That's usually Adult Protective Services or something like that's going to get involved, and that doesn't happen very often. But it is a good place if you know that you would want somebody to care for you. If you got to a point where you were unable to care for yourself, then that's a good place to put that. And once again, it can be your agent or it can be someone else that you choose. And then the last part is part 4, which is the effectiveness and signatures. You decide when it becomes effective. Most of the time when I do a living will, I suggest to patients that it become effective on the day that it's signed and terminate at death. The critical conditions planning guide does not have to be notarized. It just has to be witnessed. And it just needs to be witnessed by 2 people that are not related to you by birth or marriage. Now, I have had people that really felt strongly about a notary, and I have notarized them before, but you don't have to. It's just basically signed in front of witnesses. And that's really all that is to it. And we give this booklet out to patients, but we give it out to anybody in the community that's interested. It's funded by the Archibald Foundation. Now, I also just want to bring a few things to your attention before we go. Is the first part of the booklet has a lot of reading material in it, and I think this is very good, especially if you're not sure about your feelings about certain things. It kind of gives you a little more in-depth scenarios about what can happen with certain disease processes. And then another thing that I like is page 15 is a workbook, and don't confuse page 15 and page 29. 29 is actually the legal document, but page 15 is the workbook. What I like about the workbook is, as this allows you to kind of do a pre-advanced directive, I say. It allows you to kind of work through some of the questions that it's going to ask you, and allows you to kind of think about with your thought processes, your values, and your belief system as to what's important to you, so that when you get ready to actually do the section on page 29, you know exactly what you want. Also, as Dr. Khajavi mentioned, it's great to have that conversation with your primary care physician. And I also tell people a lot of times, if you get to a place in the workbook and you're just really not sure about something, if you have time, talk to your healthcare provider about that. Ask them a question so that they can kind of give you some clinical information about certain scenarios so that you can make an informed decision. I know in some of the new medical laws, and you know they're changing them, there's a lot in the news lately, they're trying to make it where your primary care physician will be actually able to spend, they're recommending that your internal medicine doctors and primary care physicians spend an hour every year with a patient, trying to come, to understand what their wishes are in the end of life situation. Because that's the problem. A lot of us don't have the conversation. And that's the most important thing, is that you have that conversation. And I think this book is the way it's designed, it allows you to have that conversation with your family. But do know that we at the hospital are here to help you with it. You don't have to be a patient. If you would like a private appointment with me, I do take private appointments, and I'll be glad to sit down and go over the pages with you and then provide the witnesses for you if you're interested. Or you can call me on the phone. I've left my card here on the front, so you can just call me direct. If I'm not in my office, I'm out visiting patients and rounding a lot, but if you leave me a message, I will call you back. And then the acceptance of the healthcare agent, that page is really just optional. But that's just, it's there, and they will ask you to review it at the hospital. Yes, ma'am.
This might be silly. I know you have wallet cards, so you suggest that we fill this out, and do we just keep it on our car, or do we try to?
Actually,
if you're not sick, you might not have enough record to add it to.
Right. Right. Well, if you provide a copy to the hospital, we will make you a medical record, even if that's the only thing in it. And we do like to have that. That is something that Joint Commission looks at, as well as Medicare and Medicaid, that we like to have those. So if you don't have one on file, you can put it on file with us. You can give it to me, and usually if you call me and say that you filled it out and would want to bring it in, usually what I do is, if you'll just meet me in the lobby, I usually go ahead and make you X amount of copies depending on who your healthcare agents are, so that you have those extra copies for your records, as well as giving you the original back, and then we'll make sure it's put on your medical record. And we also recommend that you keep one. I like Dr. Khajavi's idea. I hadn't heard that about taking a picture of it on your cell phone. Like she said, we all have cell phones. But I recommend to people to keep one in your glove compartment of your car, especially if you travel, so that if you're ever anywhere and someone needs it, a lot of EMS personnel know to look in your glove compartment. And even if it's good to have in there just in case you're traveling and you're far off and they need to notify your next of kin, because I have been on the other side of that coin many, many times in the emergency room trying to notify next of kin that someone is in a very serious condition in a car accident. It's very hard when we don't have any information. Very, very hard. So, but if you bring it to the hospital, I'll be glad to take care of it for you.
And shouldn't your doctor have one?
Yes, I recommend that your primary care physician have one. Really, any doctor that treats you should have a copy, but your primary care doctor is the most important. as well as your healthcare agent. So if they ever need to take it with them to the hospital, they have a copy to take with them. Yes, ma'am.
Speak a little more about what services the new palliative care team will be offering to families.
Actually, I might just bring Miss Jayne Murray up here with me. Because she's a nurse practitioner, and she is actually heading up the team, and I'll introduce her to you all. Yes.
I hate to leave, but I have to go. Could I give you this information sheet right here?
Yeah.
Where? You grab it? Yeah. Can I hand it to you because make sure you got it?
Let them know that if, even if they don't have the advanced directive, that is really important that somehow that we do have contact information. Because like she said, a lot of times when someone comes through, we spend hours on the phone just trying to get a hold of anyone, and sometimes we can't even get a hold of a family member. We've had them here, and we ended up having to talk to somebody that they went to the gym with, or something like that, because we did not have any kind of resources to contact a family member. So when you fill this out, then that contact sheet would have all those numbers and contacts in the order that you would like us to contact.
Yeah, that is a good point, Pam. But I'm going to let Jayne talk a little bit about the palliative care team, because she can speak more on that than I can.
Well, I don't want to take the stage from Anna, but I'll just give you a little brief introduction. Palliative care is really considered like a bridge between a diagnosis and the end of life. We can help families and treat patients even if you're receiving your curative treatments. For instance, somebody who has cancer and they're wanting to still take their chemo treatments, they're wanting to still take all these curative treatments. Palliative care can step in and help them, whether it's with pain management or help talk about making these decisions. And if I had a family that was having difficulty about what to do with their loved one because they really don't know, I would come in, talk to them, gather all the information I could, but then I would bring people in like Anna, who's expert at making these decisions, or perhaps I would bring hospice in. I'm kind of the one who coordinates a lot of those different visits from other people, and I bring it all together and tie it all together for the families. It's not necessarily the end of life. If somebody is coming in to the hospital and they have more than 2 admissions within a 2 or 3 month time frame because maybe they have congestive heart failure, that's telling us that their symptoms are not controlled and they need somebody to help manage that and to steer them in the right direction, and that's what the palliative care team is going to do. There's a physician, Dr. Burgess Malden, we have a social worker, we have a chaplain, myself, I'm a nurse practitioner, and then we will consult with anybody that needs to be consulted on behalf of that patient and the family. Did that answer your question?
Yes. Do you see it addressing like any misconceptions, for instance, that families might have? Like Mrs. Lady back had an issue with thinking that a tube had to stay in. I know a lot of the times we have patients who feel like traits are irreversible, for instance. So do you see it addressing?
Yes, absolutely. It's really, to me, it's having a lot of those difficult conversations that your doctors perhaps don't have time for. You know, if somebody comes in the hospital and they're being consulted by cardiology and pulmonology and all these doctors, they come in and say, oh, we're going to do this, we're going to do that, we're going to do that. And when they leave, you have questions. And so I can come in and what I do is research the patient's medical history. I'll try to find out as much as I can about them, and then I go in and just have a conversation with the family and with the patient about what do you understand, what do you know, what can I, help explain. And that can take an hour, it can take 2 hours, and physicians just don't have that time. But that is my role. Yeah. Thank you for that interest.
Thank you. And one of the things that I think is the beauty of the palliative care program is last week I had a situation in the unit where we had a family, and like Jayne said, they had a pulmonologist, they had an infectious disease doctor, they had their primary care physician along with nephrology. All of those were consulted. And so what was happening is they were having a hard time making decisions because it was a critical patient. But what was happening is the pulmonologist might come in and he says, well, the lungs look better. Well, when you're talking to a family about end of life, when you say better, that's all that family heard right then. And so palliative care, the beauty of it is they kind of pull it all together to help the family understand that, yes, the lungs are better, and the pulmonologist said the lungs are better, but he's just looking at that one little piece. And the beauty of that is they pull it all together to kind of help them, you know, make better informed decisions and kind of understand how it all goes hand in hand. Any more questions? Yes, sir.
This particular document is designed specifically for Georgia.
Yes, sir.
And if you're traveling in another state, I guess whatever their laws are regarding living wills and powers of attorney would be specific to that state. I'm wondering if you would need a separate document.
No, sir, you actually don't. The only time you would need another document, if you're a resident in the state of Georgia and you're traveling in California and you have a Georgia Advance Directive, because you're a resident of Georgia, they would follow your Advance Directive and Georgia laws regarding your health care. However, if you move from Georgia to California, I would encourage you to look at their Advance Directive documents and fill out another one there. I would encourage you to do that. But it is across state lines. Like if we have somebody that comes here from Alabama or Florida, we have to honor their Advance Directive like it is written. However, if they move here, we do encourage them, because that's one of the things when I round, if you're ever in the hospital and I round on a lot of patients, not only for patient satisfaction, but also for Advance Directives. And especially if I get a referral, I'm definitely going to come see you. And what we're going to do is I'm going to pull up your Advance Directive if we have a copy of it on file, and I'm going to take it into your room and I'm going to say, Ms. Jones, we have this Advance Directive that you completed in July of 2001. Is it still current? That's the time for you to look at the document, make sure it's still current. I had a lady the other day who said, you know what, I really need to redo mine because my husband passed away 5 years ago, and I need to redo mine. So we sat down yesterday and redid it. So it's a good time for you to think about those things and look at it and redo it. Also, it's a good time to check phone numbers and addresses. And I tell people, please do not put a P.O. box on there. And the reason being is there have been times when I have had phone numbers that did not work, and I'm trying to call a family in a crisis and the phones are disconnected or that phone is no longer in service, they've changed their phone number. And then as a last resort, we have had to call the sheriff's department in that county and sometimes get somebody to ride out to that home and notify them that they need to come to the hospital. That doesn't happen very often, but that's one reason I encourage people, please do not use a P.O. box. We're not going to mail you anything to that address, but we do need a physical address on that for your healthcare agents if you do choose to do that portion.
Healthcare agents have to be at the hospital and do anything over the phone, or they physically have to be to...
No. A lot of times the nurses, especially if it's for a consent, like if Pam were charging on 6th North and she needed a consent for some type of procedure, what she does is she would just call the healthcare agent if they weren't here in the hospital, along with another nurse would witness that conversation over the phone, but they don't have to be here. Sometimes if it's very, like if it's a withdrawal of life support thing, then they would want you here versus taking that over a phone. But just surgeries and different things like that, then you don't have to be here.
Yeah, and I had that occur, I think it was about 2 weeks ago. I had a person's mother here who had sisters, cousins, and everything else, but her power of attorney was in California. So I had to call California and get a hold of him in order to get consent for what was needed for his mom. And every Florida does that. You know, we try to discuss whatever it is with the person that you have appointed to get those consents.
Yes, Ms. Beth?
That was one of my questions. I have a niece in Michigan, and after her father passed away last week, she said she wanted me to be her healthcare power of attorney, and I was like, I don't know about that far away, simply because to be physically present if something happened, because it was urgent.
Right. I mean, you might.
Recommendations regarding that?
You mean as far as being available?
Like, you know, I mean, and I know across state lines doesn't necessarily matter.
Right. I usually try to tell people that when they're considering it, the number one thing that you want to consider is that person's wishes, or excuse me, I'm saying that wrong, that the person that you appoint is going to abide by your wishes. That would be your first priority. However, I do tell families a lot of times that it does need to be somebody that you want to consider that could be here fairly quickly. And in your case, I know Michigan's kind of far away and it might not be so close, and like Pam said, a lot of things we can do over the phone, but with a withdrawal of life support or something, you would want to be there. But I'm sure if it were in that grave a situation, that you would probably already be there or en route.
She told me she didn't want to use my sister. My sister would pull the plug too fast.
Now, I've had surgeons and stuff and actually sit down and have a phone conference with the family member that was appointed that was out of state, and let them know, over the telephone exactly what the conditions are and what was going on for them to make an informed decision.
Right.
Before signing any kind of consent. So it's not just getting just the nursing talking to you, the physician can also.
And we'll do whatever we can to try to make you all comfortable so that you can make an informed decision, whatever we need to. Any more questions? Again, we thank y'all for coming tonight. And once again, my contact information is up on the board there, as well as on the card. So if you have any questions or I can help you in any way, just let me know.